It's a really nice introduction. Of course, when it's from your paid staff, but thank you very much. That was really lovely. Well, welcome graduates. Unbelievable. It's really amazing to see you all again. We're really going to miss you. But we have a vague idea that we're going to keep in touch with you over the next number of years, even beyond this demonstration we'll talk about, and you probably already know why. Nothing like this ever happens without a whole lot of folks making a whole lot of effort, and I want to start, it's small stream, maybe not Oscar length, but some version of thank yous to all the people that participated. Clearly, all of you in the room who did all the heavy lifting and the hard work over the course of the demonstration. I mean, you are to be congratulated. People will be talking about some of you will be talking about the work over the past couple of years. And the evidence of that is out in the hallway in a lot of the poster sessions that many of you put together. We're grateful for all of you who put that together. But I also want to take the opportunity to thank my staff at the Department of Health, Erin, Laura Graham, Marietta Angelotti, who've really carried so much of the weight and so much of the responsibility for the project over the past couple of years. It's really been a pleasure. We've worked with many colleagues within the Health Department and the Office of Public Health, our colleagues in the Office of Mental Health, Dr. Setterer, Dr. Carruthers, and others. And at iPro, our colleagues, much of what we do we would not be able to do without their help and assistance. So I want to call out Alan Silver and Ronnie Pryor and Tom Lemmy. Jazz Michael King, who I think has the coolest name on the planet. I've always been jealous of Jazz's name. Steve Gilliard, and of course the hospital associations, both Greater New York and Haney's, who are here today and were so instrumental really in making the demonstration even happen to begin with years ago when we were in discussions. The CMS, who provided the funding and the support, and has really been a great partner both in this initiative and pretty much in every initiative that we've undertaken relative to trying to transform payment, transform care, whether it's hospital medical home or DSRIP or other patient-centered medical home incentives. They've been a vital partner in our ability to really do the work that we're able to do here in New York. So lots of thank yous, lots of people to acknowledge, and I've probably just scratched the surface and probably left out somebody like, my mother or something like that. I have a tremendous amount of pride, as you should, and gratitude by all that's been accomplished, and I'm also, probably like many of you, humbled by how much more there really is to do. We've said, focused in these conferences and in many of our calls on really the two primary aims that we've had with this project. And those are, as you know, to improve the care and improve care continuity for the patients that are seen in teaching clinics in New York State, while simultaneously improving the training experience for primary care residents through direct experience and participation in creating patient-centered medical homes, advanced primary care in those clinics, and exposure to advanced team-based care. And we have, and you'll see during the day, I think some pretty strong and compelling evidence that we've made a tremendous amount of progress on both of these fronts. We haven't reached the goal, but we've come a long way. We're going to spend a lot of today exploring what some of the challenges were, what some of the opportunities are as we look around the bend and think about the future for both these goals and for broader goals related to healthcare reform. So you heard Erin talk about hospital medical home and SIM and SHIP and DSRIP. Lots of acronyms, lots of things going on in the healthcare reform space nationally and particularly in New York. But I like to, because it helps me to think more simply or fundamentally about what these things are about. And as I think about this project and what our ambitions were and what we saw when we went out into the clinics and into the hospitals, I think there are really a few basic things that we're really trying to achieve with our healthcare reform on the care level and on the primary care level. And the first is improving access to ambulatory care as a goal in itself, but also to be able to reduce the need for urgent or emergent care that may be primary care treatable or avoidable. The second, and this one I think is complicated, easy to say, hard to do, is enhancing relationships and building trust partially doing that through improving continuity and the continuity experience, which we'll be talking about. But trust and continuity are two of the commodities that I think are challenging in healthcare these days. Maybe they have been for a while, but really need to be worked on. The third is providing the support and resources to help residents and attendings and practices be able to care for complex patients. It's a really hard work. And when we talk about complex patients, we mean complex in all the different ways in which you might think of that, both medically complex, behaviorally, in terms of behavioral health conditions, but also in terms of just behavior, and taking into consideration all the social determinants of health. The team-based care, I think, really helps tremendously. Many of you have had, maybe for the first time, or maybe not for the first time, the experience of having care managers or social workers or even RNs as part of the team that can help you all with that work, and it's been tremendous and vital. And the second and associated piece of this is really having data, having information about your patients, so that in those interactions, you actually know what the history is and what the medications are and where patients have been and what their needs are and what needs may be unmet. And the fourth, I think, component is really working to manage transitions and handoffs. And by that I mean both as patients travel through a complex and fragmented delivery system, but also as residents travel through a complex and fragmented experience between different settings. And many of you have been working diligently around that. And then last but not least is evaluating the results, using data, being data-driven, using data to understand what's been accomplished, what has yet to be accomplished, and to make changes, using measures to think about what it is that you do. So we saw, when we went out into many of your hospitals and clinics, we saw much of that in action. It was really our great pleasure and privilege to visit about half or so of all the hospitals that are part of this program, about 62 hospitals we visited, I think, among all of us, maybe about 30, 35, something like that. Aaron, does that sound right? 34. We wish we could have been everywhere. We were tremendously impressed, as we are today, by the commitment, by the range of initiatives, by the engagement of residents, by the progress that we saw over time. Again, you think back to the first phase of trying to submit data and what's a measure and what's a numerator and what's a denominator, and think about where folks are now, as well as the many challenges and the unique challenges that different programs have based on where they're located or how they're constructed and so on. We came a long distance. Our first visit to a local hospital, I remember there was a first-year resident coming off call who looked very tired and was kind of looking at these bureaucrats who came in from Albany, and maybe it was the fatigue, maybe it was the first year part of it, but she said to us, you know what we call PCMH, we call it the paper-centered medical home. And at that time, it was, the perception this is all about documentation, it's all about proving something, it's not really about moving care, to more recent experiences that we had in the last visits, where we saw presentations, very compelling and interesting presentations by residents, where they were basically going through PDSA cycles of improving the process of care in the clinics and taking on problems in a relatively short period of time and coming to great conclusions and also being able to make some difference. And so there was a tremendous amount of territory that was covered in that period of time. So it's been really a great journey. I'm going to move on to the next part of the presentation, but I just, again, want to say how pleased we are, and I think you're in store for a really interesting day today. There is, of course, as I mentioned, a larger context to what's going on in healthcare these days. New York, and many of you are pretty busy with a lot of those changes. There are a lot of initiatives going on in healthcare, and there's no better person, I think, to address many of those trends and what's going on than Dr. Howard Zucker. Dr. Zucker is the acting commissioner for the health department in New York State. And I'm going to say just a few things about his CV, but let me just tell you, he has the kind of CV that makes many of us feel like slackers, as you'll hear in a moment. Dr. Zucker is a native of the Bronx. He earned his MD from George Washington University at the age of 22. I think I was still trying to figure out what I wanted to do with my life at age 22. He trained in pediatrics at Johns Hopkins, anesthesiology at the Hospital of the University of Pennsylvania in pediatric critical care medicine, pediatric anesthesiology at the Children's Hospital of Philadelphia, pediatric cardiology at the Children's Hospital in Boston and Harvard Medical School. Before joining the State Health Department in September 2013, Dr. Zucker was a professor of clinical anesthesiology at Albert Einstein College of Medicine, Yeshiva University, and a pediatric cardiac anesthesiologist at Montefiore Medical Center in the Bronx. He's also served as the Deputy Assistant Secretary of Health, where he developed the nation's Medical Reserve Corps, which today is run by the U.S. Surgeon General. He served as the Assistant Director General of the World Health Organization. You get where I'm going here, right? And not on here is the fact that you're a lawyer, too. So somehow you didn't mention that. Is that, you say that when you talk to the lawyers, right? And just in case you think he's been doing nothing since he came to the department, he's also guided the department, as many of you know, in New York through many interesting and complex crises and initiatives. They include iStop and medical marijuana and hydrofracking and Ebola and healthcare reform writ large. So please join me in welcoming Dr. Howard Zucker.